So our next speaker is Sean Kaufman. He is the CEO and founding partner of Safer Behaviors. Before becoming a CEO in 2011, Sean was a senior associate and director of the Science and Safety Training Program at the Rollins School of Public Health at Emory University. And he was responsible for training professionals working in BSL-3 and BSL-4 laboratories around the world. So thank you very much for joining us.
Well, good afternoon. Before coming today, I was trying to think about how I wanted to start the presentation, being that it was an applied presentation. And I want to thank Dr. Wells for setting me up quite well, because I'm going to give an oral history of my 27 years of serving with infectious disease and public health. And it was actually quite ironic. Yesterday, I was watching a show, and I would like to say I was watching it with my children, but I wasn't. I was watching it, and it was Superman. And the S came on, and it was a part where the father was telling Superman that the S stood for hope. And my first experience in what I do started 27 years ago, back when I was an HIV counselor, back when HIV didn't have a solution. And when you were diagnosed with HIV, there really was not much that could be offered other than you were going to wait it out, go into an AIDS diagnosis, and eventually succumb to AIDS-related complications. And the very first positive case that I ever had to do a counseling session with was a gentleman that walked in the front door, HIV positive, wearing a Superman shirt. And I think, to summarize, I start at the very ending, so to speak. I think one of the biggest things that we can do specific to infectious disease is give people hope. That's one of the best things that we can do. And if we take that away, then that hope, when it goes away, will cause outreach. So I'm going to do some oral history over the last 27 years. I'm going to share some and put some faces, but I will give you a surprise. Here we go. This is the biggest surprise. I am not a scientist. I'm not a microbiologist, virologist, or parasitologist. I'm a behavioral scientist. And if you don't know what behavioral science is, I'm glad we have social scientists here. It typically is a science that determines whether or not Florida State, undefeated ACC championship, gets into the college playoffs or not. I'm a Georgia fan, go Dogs, and I'm still irritated about that. But anyway, that's the kind of science that we're talking about. I'm not discrediting behavioral science in any way, but I am a behavioral scientist. I am fascinated at the behaviors with and around infectious diseases. I have been for over 27 years. And the good news is that job security lies in infectious disease because it is a ticking time bomb. And if I start very simply by saying, look, Maslow was published, and personally, when I look at him through psychology, he was misdiagnosed, because he's really giving you a solution for what you do in emergency situations specific to infectious disease. You basically give people what they need. You ensure that they have safe food, water, shelter, that they feel safe and secure in both body and mind, that they're connected with their communities and their loved ones or the places in which they work, and that they're engaged or involved in some way or another. And if you give them all those assurances, they can rationalize and look at risk in a very rational manner. And again, I'm not trying to oversimplify, but I am saying that when you challenge one of those basic needs, this is where outrage begins to occur. And what that means is you're challenging these basic needs, and that means that mental noise is produced and the need to behave is increased and the ability to rationalize is decreased. I don't think I'm telling anybody anything they don't know, but if you simply want to try this out on yourself, you just take a deep breath, blow it all out, hold your breath until you can't breathe anymore. And then when you go to take another breath, just block that air from going into your mouth, and you will see what a challenge to the basic need feels like. As a behaviorist, it's always very surprising when people are shocked following a hurricane or some major natural disaster that people go out and start misbehaving. We call it behaving because they're actually trying to survive. They have basic needs that are being challenged. And so it's not a surprise to us when people say, well, I'm just shocked that people are behaving in this manner. Now, it's not shocking to us. They have basic needs that are being challenged. They're afraid, and they're going to do what they need to do to take care of themselves or their families. The first thing I want to point out in minimizing outrage specific to infectious disease are lessons that we learned in HIV and in SARS and in Ebola in West Africa in 2014. I know my bio goes back to Emory University, but I've also served at CDC, WHO, the state of California, and continue to have contracts with many federal agencies and organizations. One of the things that we've seen that poses a great risk to us is the psychology, and you can almost say the psychology of any type of chemical or environmental event in infectious disease. The differences between how the general public views a threat and how the scientists do. See, the general public, when a threat is proposed primarily in infectious disease, they fear first, meaning they become very afraid of it. And then anyone and anything associated with that fear or that risk is stigmatized. So, for example, in HIV, we saw individuals who, believe it or not, scientists actually called HIV grid at one point. We saw a little bit of this in monkeypox. I got an interview request from CNN. He said recently with monkeypox, can you believe we have another gay-related disease? And I said, let me get this straight. I just want to understand you. You actually think a virus cares about whether someone's lifestyle is that they're gay or straight. I'm just trying to understand, because it blows me away that perspective occurs. So there's fear, there's stigma, and then there's denial. I know in SARS 2003, when I was at CDC, Chinatowns were completely shut down because anybody who was considered Chinese was associated with that virus. And so Chinatowns in the United States, even though there's no association with SARS cases, were completely shut down as well. And when we talk about Ebola, as a individual that not only served at Emory University and prepared and trained the nurses for the first two cases of Ebola being treated in the United States with Dr. Kent Brantley and Nancy Ribel, but also traveling back and forth from Liberia and Nigeria. And being a football coach, I was stigmatized quite heavily once those two nurses in Texas became ill with Ebola. The reality is that they then deny science. It's the general public. So you've got fear, you've got stigma, and then denial of all science. Now, from a scientific standpoint, we're just as risky because, see, in West Africa, we had a lot of doctors and a lot of healthcare providers get sick with Ebola. And so basically what would happen is if you go into work and you're feeling quite tired or feverish, you don't think it's Ebola, it's malaria. It's got to be some type of malaria infection. It isn't Ebola. You deny that it could potentially be something you were working with. Then when the malaria prophylaxis, the malaria medication stops working, you start fearing that maybe you could potentially have been exposed. And then the stigma of, I should have known better, and hiding and going to clinical containments and not telling people that you've been exposed begins to happen. And we've seen this multiple occasions, meaning from the very beginning with infectious disease, we have to also take a look at the people that we're working with and the differences in which they're going to perceive those risks. The second thing that I want to bring up, this is Norma Wallace. Norma Wallace was a survivor of inhalational anthrax during the 2001 anthrax attacks. I was privileged enough at a much younger age to serve with CDC in Trenton, New Jersey, with about 1,400 postal employees who were exposed to Bacillus anthracis in the aerosolized and even cutaneous form. Norma was on her hospital bed when the CNN ticker said 45-year-old African-American woman is positive for inhalational anthrax in Trenton, New Jersey, meaning she didn't find out she had anthrax from her doctors. She found out that she had inhalational anthrax from CNN. And unfortunately, our problem with communication has gotten amplified even more with social media. And if we're going to try and minimize outrage associated with infectious diseases, we're going to have to do something a little bit better than what we're doing. Meaning, if there's a 24-hour news cycle and people can look on their phones and social media 24 hours, we probably should be generating information in the same type of fashion and competing with this misinformation and disinformation that exists in the community. Meaning we give people a place to go for trustworthy information, a place where they can interact and ask questions. And regardless of whether those questions are asked over and over and over again, you're still there to give them a particular answer. So again, I say quickly, which means try to be first, frequently, very often, and then with empathy, putting yourself in the position of those who have been exposed or are scared. This has nothing to do with infectious disease, but I thought it was very important. And being somebody who's providing oral history, I was in Malaysia 4 days after Malaysian Airlines went down. And being that I am not only a life coach, but also a counselor, I was asked if I would facilitate a crisis counseling session for those who had family members on Malaysian Airlines 370. And I wasn't expecting, to be honest with you, I wasn't expecting to show up and having hundreds of individuals in this small little group. I didn't have a good game plan. And one of the activities that I strongly recommend if you ever want to use it with communities who are in outrage is give them a ton of sticky notes and say, I'd like for you to tell me what you're feeling and what you're wanting right now in this moment. And so in all honesty, this exercise was done to buy me time and to try to understand what they were feeling and wanting and thinking in that moment. But these are real answers from individuals who had just lost or not lost. They were hopeful at that point that their loved ones would be found and that something would be given to them in the near future. The moral of the story here is, and it's been an exercise we used in anthrax with the postal employees. We've used it in H1N1 in Mexico City. When there was an outbreak of H1N1 in Mexico City, we used it in Ebola as well. When you're trying to understand your community and try to understand what they want rather than assume, simply ask, listen, and then do your best to respond to those needs. Anybody read this? Anybody see the top answer there? What's the top answer? It was the top answer in a major theme all the way through. Anybody know? Anybody see it? It's said 3 times. I don't know. You probably can't read them. Back to normal. That was the biggest one. I just want things to go back to normal. The second highest answer was this one. I just want my answer or my questions to be answered honestly. And that was a big issue because at that time we were working with Malaysian Airlines as well, and they were answering their questions as honestly as they could. But the reality is there was just not much information they had. And if they didn't know, rather than saying we just don't know, they kept trying to say the same things, and it wasn't passing off as a good message. During the attack, the anthrax attack in 2001, we had to provide postal employees with antibiotics for, at first it was only 25 days, then it went to 40 days, then it went to 100 days. We had to change the recommendation over and over again based on studies that were shared with the United States during that time about the germination and how long a spore can germinate in the lung for. One of the things that we saw is the more we got the community engaged to support those that were directly affected, the less outrage existed, meaning we still to this day have these posters and actually have connected with these children who are now grown adults. But get the community engaged in their own solutions and finding answers to the problems. I think that there is healing in that. It may not be reconstruction. I heard the question earlier, what can the community do to, in essence, solve the problem? I don't necessarily know if solving is going to happen, but healing is something that can be a part of that solution. It may not ever get better. And I know still to this day, there are postal employees that were infected and still struggle with the psychosocial and physical ailments of the disease they picked up. But getting the community engaged and involved also helps fight stigma. The postal employees had children. Those children were rejected on playgrounds because they knew their parents were postal employees. And so they were ostracized and stigmatized. And so by getting the community involved and participating, it actually begins to minimize that stigma as well. If you act, please do me a favor, inform. This is a very famous story, at least for us, because right about day 20, we switched the postal employees from ciprofloxacin to doxycycline. And the next day on the newspaper, it said postal employees getting second-class treatment as compared to politicians. And so what happened and what the science was that politicians come to DC and they go home. And when they came to get their medications, we gave them ciprofloxacin for 60 days and sent them home because we knew we wouldn't have access to them. The postal employees received 10 days of Cipro, but during that time, we were going to do the research on Bacillus anthracis and found that it was sensitive to doxycycline, which was good news because it's not only cheaper, but it has less side effects. And we have more long-term studies on doxy than we do Cipro. So the postal employees were actually receiving better treatment because it had been scientifically tested. But when we made that switch, they compared the cost of the antibiotics and determined publicly that the politicians were receiving better treatment than the postal employees were. So if you act, even if it is in the best interest of those you're serving, please make sure that your information that you're providing is very clear as to why you're acting in that fashion. Defer to expertise. One of the things that we've seen with infectious disease is that a lot of times people will be proud. They will have a lot of pride. They'll stand up and they'll talk about things they probably shouldn't talk about. I was asked 3 days before Dr. Kent Brantley and Nancy Ribel were to arrive from Liberia at Emory University. I was finishing my NIAID grant for the 10 years of working in high containment labs, and we were asked by the head of Emory Healthcare to review the medical staff and whether they were ready to treat a highly infectious patient with Ebola. This would be the staff that would treat somebody who was sick from CDC, somebody who would have an exposure at CDC during their BSL-4 labs. I asked 3 questions, and I would encourage folks, if you're ever trying to evaluate preparedness, to take a look at this. The first thing that I asked is, how do you don and doff your PPE? That is a very important characteristic when you're working with infectious diseases. Something that was very scary when I witnessed those behaviors. I saw some things that I was not happy with. I then asked the second question, how would you handle a spill? They were under the impression that janitorial staff would come in to clean up a spill, and I said, not with very sick Ebola patients. And these are latent stage disease Ebola patients, which will be shedding high quantities of bloody vomit or diarrhea at unpredictable times. How are you going to clean a spill? They weren't ready for that. And my final question is if you had to evacuate an Ebola infected patient, highly infectious, because there was a bomb threat or some type of fire event, what would you do? There was no game plan. My conclusion was I didn't think they were ready. And here's the defer to expertise. We weren't healthcare providers. We didn't know anything about medicine. But one thing that we did do is we worked with Ebola, and we knew highly infectious diseases in a lab every single day. And together we developed a concept called clinical containment, where we worked together with healthcare to ensure that highly infectious patient was taken care of. Dr. Kent Brantley, which writes in his book, by the way, received an experimental drug. And during that time when he received that experimental drug, he looked healthy, so healthy and amazing that we said, what would you like to eat? This was on day 3 of his treatment. It was ZMAP. And he said, I'd like a Chick-fil-A combo, #1 with a sweet tea. And we got that Chick-fil-A combo, #1 with a sweet tea. And as he got halfway through the sandwich, and this is not medical information I'm releasing because he wrote it in his book, he had a bout of diarrhea that shot all over the room, including the nurses that were serving in there. And it was bloody. And it was really good that we had great PPE, a spill kit, and a good plan for how to respond to that. Again, being prepared and deferring to expertise, meaning sometimes you've got to go places you haven't gone. I want to talk a little bit about, when we talk about infectious disease, I want to talk about protecting your workforce. One of the things that blew me away in COVID-19 was I have a training center with a lot of personal protective equipment. And there are some healthcare agencies that I've served, and they called and they said, hey, Sean, we need your help. We are intubating very sick COVID-19 patients. They are the most virulent. They're close to death. They're intubating them, but they don't have any PPE. Can you please bring some? And so I would get my PAPRs and I would go. And as I would walk into the hospital, there would be staff outside of the hospital wearing full masks. I mean, it was the prioritization of PPE just wasn't there. They weren't taking care of their staff. The people who needed the PPE the most were the people that didn't have it. And when we serve internationally for outbreaks like Ebola and cholera and all the other outbreaks that we've served on, we use space, we use triage. We never bring people to hospitals where babies are being born and broken arms are being fixed. It didn't make any sense. And it didn't. You have to protect your workforce, because if your workforce goes down, you've got nobody left. And that was absolutely critical. We know that people are going to make mistakes in the line that we work, whether it's chemical, radiological, or biological. And if you set up a culture where someone makes a mistake, gets fired, then they'll never, ever tell you about any safety concerns. They'll actually just sweep them under the rug because they're fearful for their job. You have to have a highly reliable organization. You have to have psychological safety within your institutions, meaning you've got to protect your workforce by giving them the assurance that you expect them to mess up. And when they do, you expect them to share that so that you can correct it, minimize it, and prevent it from ever happening again. I also want to point out something. This is Nina Pham. I sat on her court case as an expert witness against the Texas hospital where she got sick from with Ebola. When we sat down with Nina and we said, Nina, tell me how you prepared. One of the reasons why I was sitting on that court case is we had not only prepared the Emory staff for 3 days, and we did about 15 hours of training with the Emory staff. We cut their team down to about 10, 12 staff members, had an A team, and then I stayed there 17 hours and watched over those staff members and everything they did. When we talked to Nina about her treatment of Duncan, she basically said, Nina, your patients have been cleared, and we got a suspect patient with Ebola down in the emergency room. And Nina said, I don't know how to deal with Ebola. I said, well, let's go over and look at Google. And they walked over and typed in Google, and they popped up the CDC's recommendation at that time. And Nina and Amber started their job, and both of those nurses got sick. And here's my recommendation. This is a big problem. It'll come up in the next slide. When you deal with infectious diseases, be very, very careful with these universal recommendations. In this case right here from CDC, which is a credible source of information, it asks you to remove your gloves and then with bare hands take off gowns that could be potentially contaminated with vomit or diarrhea. That's bare hands. And if you want to know how bad that is, just take a look at your fingers and look at the cuts and tears around the cuticles that you have. And any virus during a very infectious patient could very easily be transmitted through those cuts and tears in your skin. So even though CDC is putting the information out, this did not apply in this particular environment to what those nurses should have been doing in that environment. So make sure that you're protecting your workforce and your assets. Second to last slide here, I want to talk about empowering rather than prescribing. When we come to infectious disease, this was a sign in Liberia. It was in Monrovia. When people are looking for guidance, and I hope I set up the next couple presentations in risk communication, I really do. When people are looking for guidance, it is best for you to stay away from telling them what not to do and telling them what they can do instead. Replace those messages. Telling someone not to do something does not give any hope, nor does it give them any guidance on behaviors that would be considered healthy or safe in that environment. When we got to Liberia, it was the scariest in Monrovia, and we flew to River G. We basically were able to fly around the country very early on. I went with Department of State. They asked if I wanted to go to with CDC or NIH, and I chose, believe it or not, Samaritan's Purse. Anybody know Samaritan's Purse? They are a group that have over 10,000 workers on the ground, but not only that, they also had fixed wing aircraft and helicopters. And we were able to move around West Africa better than the military was at that point because we were early on. It was really, really bad. But here's the deal. This is what really was very, very sad. Public health had made the decision that if you wanted treatment for Ebola, you had to go to a treatment center. Yeah, well, if you went to a treatment center, visitors weren't allowed. And quite honestly, there were people that said, I'm not going to bring my child to a place that's going to die alone. And I'm not going to bring my parents to a place that's going to die alone. And so I'm quite honestly just not going to take them to the Ebola treatment center. And the response was, well, then you're not going to get treatment. And that wasn't good enough for the agencies that we served. We went in and started teaching people how to take care of Ebola patients at home safely because they were simply refusing to follow what was prescribed to them. Same thing goes with death as a result of burial. There were people that would show up for the bodies of those who had passed, and they said, well, we don't have them. They've been cremated, and it became violent in some places as well. So again, make sure that you're empowering people rather than prescribing to them. Last but not least, I gotcha. Last but not least, this means a great deal to me, both of these cases, because I was personally affected by both of them. The one on the left is Princess Diana, an award of HIV positive children, where she took off her gloves, hugged on them, carried them. Oh man, she received so much scrutiny for this. But the stigma associated with HIV took a dive that day because she led. She saw the humanity and she believed in the science, and she led the way. And that was a beautiful day because you could see it. You could just see the stigma and the, and she took so much heat for that. And President Obama did an amazing thing. He not only hugged Amber and Nina and took photos in the Oval Office, but he also had healthcare workers that were returning from Liberia who had worked and provided compassionate care for Ebola-infected patients, and he hugged them as well. And I don't know if you remember, but there was Governor Christie in New Jersey who was trying to hold nurses in captive and putting them in tents. And I was on my way home at that point, and Georgia was starting to say, we're going to have to put you in a tent. And then he did this, and then all of a sudden, all that just disappeared. Leadership, I'm going to end on that note, is probably one of the most important things that we need during infectious disease, because we're up against not only a lot of fear and emotion, but we're also up against a lot of stigma and need for information, credible information. I want to thank you so much for the opportunity to be here. And I guess at this point, I'll take questions. Thank you. This is like the classes I teach too. And don't worry, you don't have to ask questions you don't have. I thought I was getting off.
So one of the questions I wanted to ask was like, why do you think with trying to understand the behavioral aspect of trying to treat infectious diseases, why do you think it takes so long for some leaders to maybe find the incentives to, when maybe, you and I can sit here and say like, well, it's to help people, why do you think in the behavioral aspect, it takes a while for those incentives to kick in?
It's a tough question, because the question is it really a matter of behavior? Is it a matter of public health? And the question could be framed, why does it take public health sometimes a hard time to kick in? I think there's a lot of barriers. I won't speak about COVID because I don't want to. It gets into the political aspect, but let's go to HIV. What stopped awareness in this country about HIV and potentially led to mass transmission of an infection that we knew about scientifically? What was it? Anybody know?
Identified the primary people that had it by the 4-H factor.
We did, but it's even worse than that. When politics gets involved in public health, it's people that suffer the most. And in that time, HIV was completely denied by the political administration. And because of that denial, an infection spread like wildfire. And we can go the same route with future and past epidemic and pandemics as well. Good deal.
Question what it is regarding COVID-19.
Oh, okay. Well, just don't run me.
Okay,
Yeah.
a virtual audience member asks, with COVID-19, it has been hard to encourage people to do social distancing and wear masks because a lot of people say the science isn't there. Does properly peer-reviewed science help?
No. No. I mean, listen, ladies and gentlemen, let me ask you all, just by show of hands, how many of you like snakes? Good. All right. How many of you don't like snakes? Does science help you determine whether you like snakes or not? How many of you will bungee jump, scuba dive, parachute? Listen, risk tolerance is determined on an individual level. It's determined on an individual level. And so for the person asking the question in the remote aspect, you could have the best scientists in the world come to a conclusion, but if they do not see value at an individual level, it's going to be very hard to convince them to behave. That's just the truth. Okay. Thank you all very much. I appreciate you.